Imagine this: a patient walks into your clinic with neck swelling and difficulty swallowing. What's your first thought? It could be something as simple as a benign thyroid swelling or as serious as a malignancy. Today, we're going to break down how to systematically examine the neck and uncover what's really going on. Let's start with inspection. Now, when you're inspecting the neck, always observe carefully. Look for any asymmetry or obvious swellings. These could give you your first clue. Next, check the skin for scars or discoloration that might point to past surgeries or underlying conditions. And here's an important one: look for distended veins. If you notice that, it could be a sign of superior vena cava, SVC, syndrome. Now, let's pause and talk about SVC syndrome for a moment. What could be causing the obstruction? Well, malignancies are the most common culprits, things like small cell carcinoma or squamous cell carcinoma of the lung. But don't forget other possibilities like lymphoma, thymoma, or even metastasis from breast or prostate cancer. There are also non-malignant causes you should consider, like mediastinal fibrosis, which can occur due to TB or syphilis, or even thrombosis from long-term catheter use. So, always keep these in mind as you examine. Next, we move on to palpation. Here's where you really get hands-on. Start by palpating the lymph nodes systematically. Focus on key regions like the submental, submandibular, and cervical lymph nodes, and don't miss the supraclavicular nodes. Now, about the scalene lymph nodes, you'll find these over the scalenus anterior muscle. If they're large and fixed, it could suggest lung malignancy, while hard and craggy nodes might indicate tuberculous lymphadenopathy. And of course, the Virchow's node, you've heard of this one, right? It's also called Troisier sign and often points to malignancies in the GI or GU systems. But there's more to it than just palpation. To understand what's going on, you need to think about lymphatic drainage. For example, the parietal pleura drains into the axillary nodes. The right lung and left lower lobe drain to the right supraclavicular node. And the left upper lobe drains to the left supraclavicular node. Here's a quick mnemonic for this: PAL. P. Parietal pleura axillary nodes. A. All of the right lung right supraclavicular. L. Left upper lobe left supraclavicular. Now, coming back to SVC syndrome, there's a key clinical feature you shouldn't miss: the pattern of venous distension depends on the site of obstruction. If the obstruction is above the azygous vein, the chest wall veins will be less prominent because collateral pathways are fewer. But if the obstruction is at or below the azygous vein, you'll see prominent collateral veins draining into the IVC, causing significant distension. Understanding this pattern is crucial in identifying the severity of the obstruction. To wrap up, remember these steps. Inspect for asymmetry, scars, and distended veins. Palpate lymph nodes systematically, paying attention to significant findings like Troisier sign. Correlate your findings with the lymphatic drainage pathways to localize the pathology. Always keep SVC syndrome in mind, especially in malignancies. And that's it for today. Thank you for tuning in. Remember, diagnosing starts with a good clinical examination. If you enjoyed this, follow Cephaly for more engaging medical lessons. Let's build a smarter, stronger future together.